Hi, my name is Sarah Lokari. I'm a doctoral student at California Southern University. In this presentation, I'll explore panic disorder through the lens of emotion, motivation, physiological mechanisms, cognitive appraisals, and evidence-based clinical interventions relevant to diverse populations. So, let's begin with the diagnostic features of panic disorder as found in the DSM. So, panic disorder is characterized as recurrent and unexpected panic attacks. Panic attack is an abrupt surge of intense fear or intense discomfort that reaches its peak within minutes, and during which time 4 or more of the following symptoms occur: palpitations, pounding heart, accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea, abdominal stress, feeling dizzy, unsteady, lightheaded, or faint, experiencing chills or heat sensations, paresthesias, derealization, fear of losing control or dying. Panic disorder can be conceptualized as a dysregulation of threat detection systems where benign internal sensations are misinterpreted as signs of imminent danger. This misinterpretation activates intense emotional and motivational responses, leading to panic attacks and avoidance behaviors. The psychological processes of panic disorder. Clark's cognitive model of fear response. There is a heightened response to internal changes and an internal change. So we'll use an example of increased heart rate. And then the individual has a catastrophic misattribution related to the change in their internal state. So their heart rate increases. Catastrophic misattribution is, I'm going to die. That's a perceived threat. Or I'm going to have a heart attack. That's the perceived threat. The perceived threat causes additional increased internal changes because our threat detection system activates our sympathetic nervous system, which causes a positive escalation of panic. So this is seen as a positive feedback loop. And notably, panic disorder is characterized by a fear of having additional panic attacks and avoiding panic-producing stimuli. Also associated with panic attacks is overall reduced self-efficacy over time. The individual starts believing that they are unable to cope with panic attack, and that helps maintain the disorder. Notably, panic attacks can be, over time, lead to classical conditioning where there's a pairing between the change in internal state, the misattribution, and the panic attack itself. It leads to a learning. It's a classically conditioned condition. Physiologically, panic disorder involves heightened autonomic reactivity, particularly within systems responsible for detecting bodily changes, the interoceptive systems. Interoceptive hypersensitivity amplifies awareness of internal states, while chronic stress contributes to the dysregulation of the HPA axis. Respiratory theories of panic disorder suggest that dysfunctional breathing or dysfunction within the respiratory system can cause panic disorder due to an imbalance between oxygen and carbon dioxide, so the inhale and the exhale. Hyperventilation is one of the body's attempts to rapidly expel CO2 accumulation in the body, but it contributes to additional panic symptoms such as shortness of breath, heart palpitations, dizziness, trembling, and numbness in the body. Further support for this is found in the high levels of respiratory comorbidities associated with panic disorder, which will be discussed further in this presentation. I also wanted to mention here that suffocation alarm is a threat detection system within us, and some individuals have a hypersensitivity already in their suffocation alarm system, and in and of itself can cause dyspnea, which is the sense of difficult or labored breathing. So individuals who are already hypersensitive are more prone to developing panic disorder. All right, central fear processing systems. So neuroimaging studies show that panic disorder affects both fear processing and fear regulation systems. Hyperactivity in the amygdala and insula increases threat perception, while reduced prefrontal regulation limits the cognitive modulation of fear responses. Reduced prefrontal cortex activity limits the cognitive modulation of fear responses. So patients with panic disorder have hypersensitivity in the fear network, and it takes less stimulation from the environment to activate fear. So in the threat imminence model, there are 3 phases that are considered to be our defense response. So you have your pre-encounter defense, which is your biological wiring. Your post-encounter defense, which is what is activated when you have identified a threat in the environment. So you're going to have kind of 2 different responses here. You're going to have the upregulated response, which is the startle response, immediate motricity, mediated by the ventral periaqueductal gray area. Or you're going to have a more subdued, still activated response via the ventral, prefrontal, and anterior cingulate cortex. Next, you'll have the circus strike, which is your defense system for an imminent threat, and that's activation of the movement, motricity, your fight or your startle, which will be mediated via the dorsal periaqueductal gray area. The hypothalamus and the dorsal periaqueductal gray area begin to increase activity within the body. Other neuroanatomy involved is the amygdala, the insula, the anterior, dorsal, and mid-cingulate cortex. The prefrontal cortex is involved. The prefrontal cortex and the hippocampus are involved in the downregulation of panic, in the periaqueductal gray area and the brainstem, which I go into a little bit more over here. So, if you come across a threat and you have an instinctual response via the thalamus, you're going to have amygdala activation, sympathetic nervous system activation, and changes through your HPA axis. If you have a downregulation response, your body has been surprised and is going to start the comparison of the threat stimuli to all the priors you've ever experienced, which brings online your hippocampal activation, and your amygdala is then downregulated. And then there's 2 other areas that are generally involved in fear processing that I wanted to include, and that's the locus ceruleus and the dorsal raphe nucleus. These 2 areas are involved in general arousal levels. So if you're generally more aroused, it will take less to trigger startle response. And they're also indicated in the sleep-wake cycle. The dorsal raphe nucleus is a cluster of neurons found to be active during panic states. And the overactivation of fear processing networks in the brain leads to sympathetic nervous system activation. Stress hormones, which can contribute to the misinterpretation of environmental or internal stimuli as threatening. So the defense cascade model is instinctual activation. Panic attacks represent a dysregulated defense cascade, where arousal escalates rapidly without adaptive resolution. This theory is widely accepted based on our shared similarity in instinctual responses with animals. In some individuals, freeze or dissociative responses emerge, particularly when escape is perceived as impossible. Animals have more ability and freedom to access quiescent immobility, but humans often continue on after a threat, potentially blocking healing that needs to occur and locking their system in a trauma response. So within this model, first, your system will become aroused to the potential of a threat. It will then experience fight or flight, or put fight or flight on hold into freeze. Tonic immobility and collapsed immobility occur when there's an inescapable threat, and they're distinguished from freeze, even though both are non-movement states. They're distinguished from freeze by muscle tone. Tonic immobility has a waxy movement quality to it, versus a typical freeze has a lot of tension in the muscles. And following those four is quiescent immobility, which is when rest and healing occurs. During panic attacks, the parasympathetic nervous system rapidly increases heart rate and respiration, while parasympathetic regulation is suppressed and respiration is impacted. This imbalance prolongs arousal and reinforces fear-based learning. So, the sympathetic nervous system is activated during panic attack via the dorsal hypothalamus. It's responsible for the increased heart rate, blood movement, activation of the adrenals, triggering catecholamines, and increased respiration. During this phase, digestion is inhibited, and there's a delay of physiological recovery. Notably, freezing is associated with activation of both the parasympathetic nervous system and the sympathetic nervous system. Multiple neurotransmitter systems contribute to panic disorder. Reduced serotonergic modulation as a result of dysregulated neurotransmission leads to excess or deficiency in serotonin. Both are indicated in panic disorder. Heightened noradrenergic activity and GABAergic inhibition deficits increase an individual's vulnerability to panic disorder. And chronic cortisol elevation further sensitizes stress systems. Several neuropeptides are thought to modulate various processes within panic disorder, most notably neuropeptide S and neuropeptide Y. The risk for panic disorder arises from the interaction of inherited vulnerability, temperamental traits such as neuroticism, and anxiety sensitivity, as well as early adverse learning experiences that can sensitize fear systems. As far as genetic transmission, PD is found to run in families, but only a few genes are actually associated with panic disorder, which means it's a more complex inheritance process. But some of the genes that have been found are related to serotonin and neuroepinephrine reception. Panic disorder frequently co-occurs with mood disorders, substance use disorders, and medical conditions, and particularly those involving cardiovascular or respiratory systems, which can complicate diagnosis and treatment. So, for medical comorbidities, COPD, asthma, long COVID, orthostatic intolerance, and arrhythmias. Dysfunctional breathing is found in up to 30%. Alright, so let's move on to treatment. CBT is the gold standard treatment for panic disorder. It targets maladaptive beliefs, reduces avoidance, and increases tolerance of bodily sensation through structured exposure and cognitive interventions. So typically in straight panic disorder, the exposure piece is to the internal sensations themselves. So you'll see triggering hyperventilation as an exposure therapy. And the cognitive restructuring piece that goes along with the exposure therapy changes the individual's relationship with the feared stimuli and helps reduce avoidance. Acceptance and commitment therapies and mindfulness-based stress reduction therapies are useful additions and adjuncts to CBT. So culturally adapted CBT is a great modality to use in non-westernized individuals. There's a lot of evidence that in cultures that have high levels of mental health stigma, they place a bigger emphasis on the somatic symptoms and medical components related to panic disorder. So CACBT on its own as a manualized therapy addresses the somatic components intensely, and it brings movement and breath and mindfulness and stretching exercises into the treatment, and it's evidence-based, and it's especially effective for PTSD and anxiety disorders due to its somatic focus, although it can be adapted for other mood disorders as well. Pharmacological treatments. The frontline medications for panic disorders are SSRIs and SNRIs. So SSRIs being sertraline, paroxetine, and fluoxetine. SNRIs, didn't have it listed here, venlafaxine or Effexor. Benzodiazepines are indicated for short-term use, but they're not recommended as primary treatments due to dependency risk. Tricyclic antidepressants also work well for panic disorder, but they tend to be heavy on the side effects. They're thought to actually impact the brainstem and work on the amygdala directly, but these are used less as well because the side effects can be intolerable. So in this presentation, we covered biological components of panic disorder, neurochemical imbalance, neuroanatomy differences, metabolic and respiratory contributors, as well as the cognitive components and personality factors. Thank you.